still going to be some discussion about that. And so, Raylene, it looks like you were the one that brought this forward. And so I'm going to let you kind of make a presentation and kind of give us an idea of what we're talking about. That would be great.
Wendy, did you want me to start with the land acknowledgement statement first?
Oh, I'm sorry. Yes, that would be great. I haven't run one of these for quite a while, so thank you very much.
That's quite all right. Jill, I'm going to ask you if you can move it up on the screen just a hair. And
how's that? Can you see it?
perfect. Thank you. So land acknowledgement statement. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders past and present. Please take a moment to consider the many legacies of such violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. Okay. Thank you. It was brought to my attention a while back about the Ann Deacon Crisis Center for Hope that it's not being utilized as much by law enforcement and first responders. It is being utilized by the hospital. They are referring people, and there are some private citizens that have used it. I went on the website to look at some of the information that's out there. And I know Perry provided a new form for law enforcement first responders to be able to use to determine eligibility and phone calls. So I think we're moving in the right direction. I guess what I brought up at the last legal injustice meeting, or maybe it was a task force meeting, I'm sorry, there's too many meetings, but was that under the legal injustice portion that maybe we could have the index committee assist in doing a survey amongst law enforcement and first responders to gather data on who's using it, who has used it, do they know about it, what don't they know about it. So I don't know if it's something that the index committee would like to use like Survey Monkey and bring that back to the group. If this isn't something that you guys think is beneficial, or if you do, what type of questions we should be looking at, and who we should all send it out to. When I looked on the county site, they have the online form for feedback, and I think that's geared more towards individuals that may have used it or sent somebody there, but I don't know if it's specific to law enforcement and paramedics. So I guess the first question to those in the group here, is that something that you think would be beneficial?
Anybody have any opinions or comments?
I've got a quiet room.
I know we usually do.
I know one of the law enforcement officers that responded, that submitted the email back before, was they weren't familiar with it. They hadn't used it. Another law enforcement officer had said the time that it took them to get them there and utilize the facility wasn't going to work because they were going to need to bring them to the hospital anyways. I did speak with the lieutenant that happened to be here in my office yesterday with the fire department, and he said that if we submitted something like that to Chief Vanderveen, that he might be able to distribute it amongst fire personnel, EMTs. I'm sure there's other people that we could submit something to, but just to kind of get an idea, have they been trained on what it's there for? Do they want to see it? Do they know what it's available for? Have they referred general public to it? I know the response I got yesterday was, we most likely won't use it, because typically when we get called by law enforcement to transport somebody to the hospital.
I can tell you, I'm real comfortable if the committee wants to move forward with this. We can route it to all the local police departments, to the monthly chiefs meeting that the sheriff and or undersheriff attend. Get it to the chiefs and they could disseminate it. I can tell you, based on feedback I've heard on pretty much every time the subject comes up, is that law enforcement, at least for the city of Bellingham and for the sheriff's office, don't use it because the center has no ability to hold people who do not want to be there. And in general, the law enforcement is not showing up unless there's a problem. And since they have no involuntary capacity to utilize an adult protective custody hold, which does allow law enforcement to hold somebody for up to 12 hours in a secure facility, potentially see if they can get sobered up, or if the staff can work with them long enough to get them convinced that yes, that there are some folks who can help them, and then potentially move them into services in the community. Law enforcement just isn't bothering because there's no way to keep them in one place. The other part of it is also that medical clearance. And the third part of it is that the center, reasonably so, has some pretty strict criteria as far as behavior. And so what the law enforcement, although they are frustrated because unfortunately, while we don't have those restrictions at the jail, we have others which can make it difficult. So I'll stop talking now. Barry, it looked like you.
Yeah, I just want to say, Raylene, I think it's a great idea. I think gathering as much information, especially about the communication, it seems like that's an issue. I just don't know who would construct such a survey. I know I wouldn't have any great ideas up front, but I think in practice, it's a great idea.
Thank you. Brian Anderson?
Yeah, hey, so I even had like a personal experience with this where we called on a guy that I know who's down and out, and I ran into, and the crisis stabilization center, I called them personally and they didn't have any space. They basically told to call the hospital and call 911 to take this individual to the hospital, see if he qualified. Police came and that's actually and EMS and everything came and that's what they said. And I don't claim to know what's going on in the field. I mean, but I think it would be a great idea to find out the different scenarios. I mean, we can probably guess what the different scenarios and reasons why, if there's underutilization, but I think it's a good idea to find out. I mean, I think they, what are there barriers? Are there issues? Is that information? Is it, in a lot of ways I could probably guess that a lot of time, what we've done in the city of Bellingham has been to decrease the amount of incidents that police go to that aren't necessarily criminal investigations, right? So a lot of these might be something where the police aren't the ones responding, right? So the situation I had, the guy wasn't committing a crime, but he was just asking for how to get somewhere, right? And clearly had been beat up and was in dire straits. Police don't necessarily respond to that. At least we're kind of backing out of that, right? That's been the city's goal, is to back police out of those situations. So maybe that's part of it too, right? I just don't know, but there's a lot of, we're changing the way we're policing and changing who's responding to what. And so I think if there are gaps in that, we need to find out what those are. So I, like Barry, don't probably have the expertise to write up those questions, but it seems to me that we want to utilize the services we have as best as we can, and we need to find out what's going on. But I would suspect it's not, and it could be different, right? It's different for if you're an officer out in Blaine or Everson or way out in the county, right? Like it's going to be a different reason why you're maybe not running them in, where, Bellingham, officers might have a very different reason as to why, well, we're not responding to those as much. That's more EMS and our different, other programs we have, that respond for those when it's not a criminal investigation. So I don't know, but I think those are, again, we all can sit here and conjecture with our expertise, but I think it's always good to get that data and that information from the source. So I would agree.
So it sounds like at least the folks who have expressed an opinion that this would be worth people's time and effort. We've got a small group and I know everybody's pretty busy. What do y'all see as the major areas? It sounds like one of the things we want to do is perhaps aim it at EMS, fire, law enforcement. Is there another group that it should go out to?
Dispatch.
Dispatch?
I think in general, what I'm getting is the hospitals are using it, and that there has been some members of the public that have went in and they've got a survey, or a questionnaire or a response that you can respond back to on the form center. But I think that's more for general people that have used it or have brought a loved one in. So if we're looking at just focusing on the groups that haven't been using it much, and that's kind of what I got back from Perry on the statistics, is that it hadn't been used much by law enforcement and EMS. And that was kind of one of the purposes, was to divert people from going to the jail or to the hospital, but to have this other facility. So I think if we know why they're not using it or gaps that might need to be filled in another way, whether it's changing licensing, which I know is going to be a difficult, or working on a different type of center might be beneficial. So I think firefighters, EMS, the communication center, and law enforcement. I don't know of any other ones that I'm missing right now, unless somebody else has thoughts.
Excuse me, Wendy, Jill here. We have an attendee. It looks like someone from Whatcom County Emergency Medical Services. I'm wondering if it's one of our members. Can you identify yourself?
Yeah, hope you can hear me. Mike Hilly, EMS man.
Hey, Mike, go ahead and I'll promote you to panelist and you can.
Yeah, thanks. I got the guest invite. Appreciate it.
Did you want to say something, Mike?
Yeah, thank you. Good afternoon, everybody. I appreciate joining the group, and I caught the first part of it, and I could spend a couple of seconds talking about the EMS piece of this. And yeah, we've been generally frustrated about the inability to get direct admits into there. In fact, it had been a big goal before the CSF opened that we'd be able to directly from the field, and we had prepared protocols for that, et cetera, But some of the problems about getting in there is that EMS can't wait 1, 2, 3 hours for the facility to decide if they're going to take that patient or not. It needs to be a 15-minute drop off. And early on in the organization of this, in the back of the facility where there's an entry, there was supposed to be a medical person that could do a quick scan, get that person settled in, and then they would have time to figure out what to do. And that just has not come through. I will say that we understand better why. We know that that's related to the ability to pay insurance, there's ability, their staff that might be there at night, the type of patient that might have comorbidities. And so I wouldn't lay it all on the center. However, we have definitely been frustrated with I want to say the lack of personnel that can do that work and get them in there. And so, EMS just doesn't have the time to work that out on their own on scene. So the default ends up being the emergency room where all that goes. And I can't speak for officers, but I know the particular frustration has been the lack of being able to have an ITA hold in that facility. So it's a different level of acuity of patient that can go into the mental health side. Also, the big issue is for our SUD patients, you know, they got to be sobered up a little bit before they can go in there. And so there's a time and factor that, you know, patients coming out, you know, they've been woken up from the overdose, they have a space and time where they settle in, they're medically stable, but they won't take that patient in at that moment for a variety of reasons. And so, yeah, that's been frustrating on our part. We like to see the ability to direct divert in the field. I think we understand some of the reasons why. I do hope or would promote that this idea of the 23-hour sobering center might help solve that problem where people from the field could be dropped off, even if they were referred out of the ED, they could be sent over to the sobering center for that 23-hour hold, because it sometimes just takes about that long to figure out how you're going to take care of a patient, whether they can do MAT inpatient or if they're appropriate for outpatient, don't have any comorbidities, and then being able to navigate them out. And then indeed, if you know they are fit for the stabilization center, the Ann Deacon Hope Center, and then they could just walk across the parking lot, get in there. So anyway, I'll stop there. That was our hope, you know, several years back from the EMS perspective on that facility. And I kind of feel like we could get there, but we're missing this middle piece of that 24 hours it takes to find a place to or how to deal with that patient.
Ryan, did you have something you wanted to?
Oh, no, well, I was just gonna say, like, Mike knows, I agree with what Mike's saying, and that's great information. And even the situation I was talking about, they actually, when I called the crisis stabilization center, they said, call 911 and get him into the hospital, and then the hospital will transfer him over here later, which I think matches up a bit with what Mike was saying, but that's literally the advice even the stabilization center was telling me was have him go to the hospital and then they'll stabilize or whatever, because of these, you know, they weren't explaining them all to me, but because of their situation and the state they needed him in before they would get him there, they're like, yeah, then the hospital will work with us to bring him over there, which again, I think sort of defeats the purpose. The idea was to avoid having to go to the hospital. But I was just, from my own experience, that's literally the advice the stabilization center gave me was get him to the hospital first, then we'll figure it out from there. So anyway.
So it sounds like maybe one of the pieces of information we're missing is exactly right now, how many people that the stabilization center is accepting straight from the street without going through the hospital first, whether it's someone in one of the professional fields we're dealing with, or whether it's somebody's parent or whomever brings them in, that direct referral. So that may be one piece of information that hopefully would be fairly easy to get. And that may guide some of the additional questions that the group wants to come up with. So finding out a little bit more information, and then what would be some of the questions that we would want to ask? I mean, mine would be, okay, law enforcement, because that's where I've got the connection. Why aren't you taking them directly to the stabilization center? Jill, it looks like you've got a suggestion.
I just wanted to let you know that I have the 2022 year end and first quarter 2023 data that you're talking about. And I can screen share that if you like.
That would be great. And then maybe afterwards you could send it out to the group.
Yeah, of course.
Perfect. Thank you.
And Wendy, Mike Hilly here again. I can add that Perry Mallory, and actually I think this is what it is. He's had a utilization record that they've been keeping for the last year, because we have been in these weekly conversations to figure out why this not happened. I can tell you for a fact there have been 0 diversions from EMS, and as a matter of fact, just to highlight this, there was a call here several weeks back where EMS went into overdose call. They picked him up, took him to the ED, spent some time there. Then that patient went home. 911 was called again the next morning by that same patient who said it was time to get in, didn't want to overdose again, was scared of dying. So EMS said, fantastic, I think we'll take you over to the CSF. This is an awesome place for you to go. It's been 24 hours since your overdose, and they wouldn't take him at the door there from EMS, which frustrated a lot of people. But I can tell you there's been 0 from EMS from the field since that place opened.
So one of the things I'm hearing, Raylene, partially from you, partially from Mike, is that maybe it's going to be at least until potentially an enhanced ability to be able to take people who are a little bit out of control or on an involuntary basis, that maybe the center is going to be used primarily for people who have been stabilized to an extent from the hospital, or who I seeing that LEAD and GRACE and some of those programs that have been working with folks for a while, who may have identified, I need a little bit of help and I need somebody to help refer me to backdoor services, that maybe the original intent isn't going to be possible with the constrictions that are in place right now. It might be something to work for, but I don't know. What feedback from other members?
You know, Wendy, the one thing that I think that some of the smaller agencies in Whatcom County don't necessarily know what this place is, what they do, and how they could get somebody there or refer them. And I think that's why there was a question on the survey. If we did a Survey Monkey and we sent it out to law enforcement and EMS, one, I thought it'd probably be best if it was anonymous so that we could get a more accurate response, but maybe leaving it open to, I'm an EMS worker, paramedic, or I'm law enforcement, and say, do you know what the Ann Deacon Center for Hope is? Have you used it? Have you referred anybody to it? If you haven't used it, why haven't you used it? I mean, I think those are some of the questions so that they can be brought back to the task force as a whole to say, hey, this is what we're getting back from law enforcement and EMS, and you know, we need to do better on either letting them know what's there, or they're letting us know that they can't use it based on these reasons. So it might help support a 24/7 or 23-hour sobering center. It might help get more funding for that if we know what the needs are and we have the data to support it.
Okay, what does the rest of the group think about that?
You know, I think that's a great approach, Arlene. It does. I do wonder. So we know there is a certain amount of people that get sent to the ED, but if they're medically stable, they're actually sent out to the waiting room to wait. And it would be good to know how many people that got sent to the waiting room just gave up and left, because I think that's a component. And then for EMS, I know that almost 50% of the people we see in the field refuse to go to the emergency department. So that amount of people could potentially be diverted if they knew they weren't going to the ED, generating a bill to only sit in the ED and not get a social services outreach. So I don't know how to squeeze that out, but I think that's a missing number in that.
Maybe one of the things we want to think about, I mean, that we could go down a lot of bunny trails with this. I'm going to predict that we're not going to get a very good response, but I would love to be wrong. But maybe a first step is going to be getting some really concrete single-page information out to mainly, I think, law enforcement, because I suspect EMS, that information's gone through to the aid units and the fire departments already. I think you guys do that better than the different law enforcement agencies. But certainly a one-page maybe summary out to everybody. And since there are statistics that are being kept by the health department, we could see if that made any difference before going to the time and effort of putting, coming up with the questions and sending them out and then seeing what kind of response we got. That's all time consuming. And if it's going to have a payoff, I think that's great. I don't know that it's going to fundamentally change anything over at the stabilization center. And that's just because I'm old and sometimes cynical, because I've been around for a long time. It's just I've filled out tons of surveys over my experience, over my years. And yeah, fine, you've got the information, but we don't have the ability to force people to go if they don't want to. The stabilization center has some pretty strict criteria about who they're going to take. And a lot of the folks who probably need to be there, I would suggest, are not going to be willing to go and stay. Excuse me. But it could be that the results of the survey going back to the, especially the task force, can say maybe we need to rethink what the stabilization center is going to be used for. And that how it was envisioned, and a piece of information I suspect none of you have, is that back when I was a line deputy, so we're talking 40 years ago, I was part of a committee who envisioned this exact same thing. And that is, you could take people who were semi out of control, you're not sure why, you take them to a single point, they'd be evaluated, medical would be cleared at that point, and then they would get fed into one of these systems. The reason we're now in 2023 still having this discussion is that it's more complicated than it seems on the surface. Not to say that it can't happen, but I don't want to sound like Debbie Downer, and I think that sometimes I do that, but I'm not sure how much participation you're going to get out of the folks in the field. And I don't know, even if everybody said, well, if this, this, and this would make it easy. And Mike's telling us that EMS would have to wait 1 to 2 hours in order to get somebody in and get all the criteria and screening done. They can't tie up an aid unit for that. Law enforcement can't tie up law enforcement. So I'm going to quit talking, let somebody else. I'm struggling with this a little bit, you can probably tell. I absolutely support the philosophy of the stabilization center. I'm just not sure that it can work the way we've got it set up now, and that it may need to shift so that when people have gotten through that first crisis part, they're going to understand that they need some help, and this would be a really good way of getting them a safe place to get more stabilized and then moved into backdoor services if they were available. And that might be part of the question, one of the questions we'd want to ask.
Well, just not to suck up all the air in the room, Wendy, I agree 100%. I've been here 5 years. When I came here, that was the big change that was going to happen for EMS and law enforcement. And I not being in on that visionary time frame of putting all that together, I think, at least for myself, my perception was that that's exactly what it was, is to have a place to drop somebody off in a diversion situation from the ED. I can tell you, we're doing some mapping out. One of the things that we are pushing that we'd like to do is offer some type of engagement for MAT in the street, maybe even at the time of call. We just noticed in their data a person that's overdosed 5 times in about the last 6 weeks, and 2 times with the ED, 2 times didn't. And then there was actually a point in one of the charts where this person says, okay, I'm done. I need to get help right now. Went to the ED, then left, and overdosed again on that 5th time. And so that was an engagement point. And I really think that if EMS had the ability to do the drop off over there, that person might have had that opportunity to change, or at least that process of getting sober. That was the entry point. And a lot of people feel bad about this guy because they know he's going to overdose again, and he doesn't really get on the GRACE program until he gets 15 frequent user hits with EMS. Well, from my point of view, 5 is frequent user of overdoses in EMS. So why can't we help that person and direct them to something different? And that was the hope, for the stabilization center. And I'm not sure how this relates to a survey, Wendy. I'm trying to help you. How would a survey help? From an EMS point of view, if you push this out to the fire chief, they're just going to say it's a non-resource. It's just a non-resource. We don't have that time to sit and wait and navigate and explain. We've had EMTs call the stabilization center on the phone and said, hey, I think I've got somebody perfect for you. Can you take them? And they say, hold on. And then they go through this whole list of qualifications with an EMT that really is not really appropriate for the EMT to be making that determination out in the field. And so I'm sorry, I can't wait this long. We'll just go to the ED.
Mhm. And that's what I think you run into with law enforcement too. Raylene, I've got a thought. They've been few and far between sometimes today. One of the places we may want to actually start is with the people who work at the stabilization center. And it would be a short survey or a short questionnaire saying, what would need to happen in this location in order for you to, if EMS shows up and wants to take somebody who they've scraped off the street, they've gotten, out of that overdose, at least to the point where they're relatively stable. And this is somebody who's acknowledging that they've got a problem and want help right now. What are the impediments you have within your system that might prevent that from happening? The same thing, if law enforcement comes up, pulls a guy out of the back of their unit and said, this guy needs help, he wants help. So we can, let's start maybe with the stabilization center and find out what the systemic impediments they may have from doing exactly what everybody had really intended for this entity to do. And maybe start at that point, find out what those are, and then turn around and go to EMS and law enforcement and say, if we could get rid of these things and more reasonably tell you that it's going to be 15 minutes, come, drop, and go, would you be utilizing this as a resource? I mean, it's kind of doing it backwards, but
I think that's the most, I agree with you. I think that's the most effective way to do it.
okay. Raylene, would that fit with what you were thinking about?
Yeah, I'm open. I guess it just comes back to that there's some people that don't know it's there and that aren't utilizing it to its fullest extent, or that maybe, as Mike said before, maybe we need to reevaluate what its usages are for and change that vision, because it's not going to work for certain people. So at least starting somewhere, I think, is good. I also my question is for Jill, is does the task force have the ability to use SurveyMonkey, or do we have the funds? Or
I was hoping Perry Rice would be here today so I could ask him that question. I don't know what platform the county prefers us to use, so I would have to look into that.
Okay, that would be helpful. Maybe we want to kind of tier this discussion. First one is making sure that I would assume that the health department and the center will have come up with a one-page flyer. This is what this is, and this is what it does. And here are some criteria that people need to be able to meet in order to get in. And that would be something that could disseminate out through a whole variety of different ways, members of the public on the website, but also targeted to law enforcement. I will send it. I mean, we could get it to Mike and he can get it to the fire chiefs. I'm suspecting most of them already know that, but maybe not. So that would be the first tier. Let's get it out there to make sure that people know. I also think that it would be a really good idea to consider sending it out to the folks who oversee and organize AA meetings and NAMI and all of the organizations that exist in our community that are there to support members and family members of folks who are running into issues with SUD and different kinds of mental illness. Because you're right, Raylene, I believe 100% some people don't even know it's an option. And so that maybe an informational push would be a good start. Before I keep talking, Jill, what you got?
I wanted to let you know that I can also screen share what Perry Mowry is calling a visor card that he or they intend to distribute out to law enforcement. I don't know to what extent that's been done, or they're still working it up, but I can screen share that information for you as well if you like.
That would be great. And again, Jill, if we could also get that in the packet going out after the meeting's over.
Yes.
Okay. Yeah, I see a couple of things on the exclusionary categories right now that's probably impacting the ability for law enforcement especially, but also EMS to utilize the center. But at least it would get the information out. We wouldn't even have to recreate the wheel at this point. Jill, do you have an idea of what they're thinking about as far as a timeline for this?
I really don't. Perry discussed it a little bit and shared it with the full task force. I don't know, Barry and Raylene, if you remember what he said about that at the July meeting.
I don't recall hearing a timeline. Do you, Raylene?
I don't recall. I just know that they said that they were getting ready to distribute those, and I know Tank asked if he could send some out. But I don't know if they've been distributed amongst all law enforcement yet. So that might be a question we can double check with Perry on at the next meeting. And then I guess the other thing is just coming up with questions and finding out, what platform we would want to use. And if anybody has any thoughts, is this something that we want to bring to the next joint meeting for questions, or maybe the next legal and justice meeting for questions to come up on the survey?
Well, I'm sorry, Raylene. I'm not sure. Questions for who? Questions for law enforcement, questions for the people who work at the stabilization center?
I guess for both.
Okay. I'd suggest that we do it in stages versus all at the same time. And I'd ask the committee to consider that, simply because otherwise wherever these go is going to get inundated with a lot of very disparate information.
Okay.
And I mean, somebody developed these criteria, right? That Jill's put on. So there must be good reasons behind it. Now, it could be because, Mike, you touched base with the fact that if somebody's not cleared by the hospital, then they can't bill out of the stabilization center. And that might be an impediment from EMS coming and dropping off. If EMS are the ones that said, yeah, they're pretty intoxicated, they're pretty under the influence, they're pretty out of it, but they're not going to die in 15 minutes or anything, that they're actually okay, they're in crisis, but they're not at acute level. And if that was an impediment for the stabilization center to take them, then that would be useful to know, because then we need to look at, or help them look at, is this Medicaid rules with the feds? This is the state rules. This is what the county's risk pool would say, no, not unless you do this because it's too big a liability. And then once we got clear on what the folks who are involved with this center think are impediments to this rapid deployment and diversion, then we start going to the folks who aren't using it at this point. Or do you want to go ahead and just throw it all out there and see what happens?
No, I think you got a good point there. I think finding out the impediments from the center first would be beneficial.
And then I think that should probably also go to the full committee, so that the task force knows where, that this has been part of the discussion, that we're suggesting that the information go out, and I'm comfortable in reaching out to Perry, that this kind of synthesis of information go out as soon as it can, and that it goes out to law enforcement and EMS, and I would also suggest that second tier group, and that's all the support different organizations in the community. And then we take the next step once that's out there, say, okay, stabilization center, what do you see might prevent a more fluid transfer of these individuals from the community to your center? And then the third step would be, okay, this is kind of, now you know what's there for. We've taken a look at and probably discussed, I'm guessing, in the task force, is there a way around some of these? And then going to the folks who would be the first time utilizers in law enforcement and EMS. Or does that sound too cumbersome and taking too long?
No, that sounds excellent.
No, I don't think it'd take that long. I think that's a great approach.
Okay.
And Wendy, I might add one thing is one question in that survey might be, what type of staffing do you need to achieve this? Because I know that's an issue over there. I'm not sure what is now. There may be a nurse during the day, but at nighttime especially, there's a different staffing scenario. Pioneer is so there's a new law that got put in place last year, a legislation rather, that allows EMTs now to work in diversion centers. Councilmember Barry Buchanan and I saw that down in Everett and works well. So EMTs are working in the diversion center. They provide a level of safety for patients that come in that are stable, but they need to be watched. And then it also allows a person to be with them if they have to navigate outside of the building to another facility for some type of checkup or whatever. So that might just be one of the barriers, which is what type of staffing do you have to make this safe on both sides of the facility? What it would take to get there.
Okay, so that kind of goes into that second tier. First is information, second one is from the stabilization center. What are you lacking? What is it you need? And if you had all the money and all the power in the universe, what would you do to allow this objective being met? And I think you're right. I think having additional medical personnel off hours and on weekends. And I suspect another thing that you're going to need is maybe some tweaks to the architecture inside. You don't need to have something that looks like the security cell we have in the jail, but you need something that doesn't have furniture that's easy to throw or glass that's going to break easily. And you probably need to up and have presence individuals who are security personnel. They don't have to be in uniform. They don't have to look like cops, but they have to be comfortable in utilizing de-escalation skills, but also being able to keep the staff safe if somebody kind of loses it and starts yelling and screaming and trying to assault people. We don't want that to happen. We don't want those folks to get hurt. And you know, watching a lot of the security up at the hospital, they do that really well, although they are in uniform, and uniforms can be a trigger for some of this population. So, but I think that's going to be a really good information gathering thing. And then we take that and maybe take it to that third step and send it out and say, in a perfect world, if these were the criteria we could meet for you as a riding on a, you know, driving an aid unit or in a patrol car, do you think that you would use this more frequently than we know you have been because of the data that the system has been collecting? Sound about right? Brian, Dave? They're going, no response. That's fine. Okay. Well, then the four of us.
On a side note, when Perry presented the data at the last meeting that I was at, something that came up that they weren't able to answer is when people are using this center, where are they coming from? Is it just locally? Is it Bellingham? Is it outside areas of the county? And nobody was able to break that down, and they didn't know if that was possible, but I'd sure like to see if it's being used more by individuals that are just living within the city limits of Bellingham, and how much it's reaching to the outside communities. So I don't know how we can do that, and that's kind of outside of this survey, but it is still data that I think would be beneficial.
Okay, and I guess Raylene, I'd ask you why.
How we can assist those individuals in gathering the data that allow us to know which area or which part of the county is being serviced the most by these locations, whether
Okay,
it's
So we're
detox.
talking about within Whatcom County, not assuming that somebody's coming from Snohomish or Skagit.
Correct. I'm looking at Whatcom County. I mean, I know we're gonna have people from out of the county that are periodically gonna be here, but I would like to see our people from Maple Falls using it, our people from Sumas using it. Is this primarily individuals that are in the city limits of Bellingham? I want to know how we're servicing the entire county and not just a small section.
Well, we could certainly ask Perry and see if he can go through the health. I don't know what kind of information they gather if somebody shows up to come into the stabilization center, if they ask them, you know, you have an address, where have you been staying, that kind of stuff. I think you're probably going to get a fair number that are coming from the city limits of Bellingham, but maybe not. So just because transportation and that kind of stuff. But
Even if people could put zip codes down, I think would be helpful. When they came in, I don't know if that would narrow it down a little bit.
well,
Barry, do you have any thoughts on that?
Well, I'll Mike Hilly here. I do know because we got into this with Perry several months back with and it may be changed now. I don't know. But when somebody knocked on that door, they weren't making a log of that knock on the door. So I know people have been turned away at night or whatever during the day, but there was no record of that person, you know, on that. I'm not quite sure if Perry reconciled that, but we did ask that, yeah, if somebody came and knocked on the door, or EMS came by or law enforcement came by and you didn't take them in, you still log it, the circumstances and why they were not allowed to be in the facility. And like I said, Perry's been working on that, but I'm not sure if that's been achieved. And once again, that's that gap, which is, you know, there's not really a record of everybody that we try to get in there with those demographics that you're talking about. So they may have that a little bit now, but I think that should be required from my perspective is why was somebody turned away at the door, you know, at 11 o'clock at night when they were trying to get into services.
that's probably a really good question. So it sounds like two of the things we want to have on a form or an ability to parse out data from the stabilization center is going to be, you know, where have you been living? And the second one is that the center keep track of people who show up and then they say, I'm sorry, you don't meet criteria, we can't take you. And keep track of how many, not necessarily who they were, but even just a tick count, the number of people. So that's a good request we could make through the health department. We've obviously got a little bit of time left. Is there anything else that we're missing here?
Mike,
Mike, your mute is off.
Sorry, thanks. Transportation might be a piece of that. I know that if there is an issue at the door on the intake, the patient still have to go to the ED to get that. Now, we're hoping to solve that a little bit out of the RSD division, Melora's group, because they're going to have a transportation person at FTE that would be help out with that. But once again, that's during the day. What do you do at night when that person shows up and needing to go to the ED? I can tell you quickly, we had a situation about 2 years ago. A patient showed up there, knocked on the door, said, tonight's the night. They said, we can't take you, sorry. They got in their vehicle. They knew they were drunk, got in a vehicle and went to the ED, sat around for a couple, 3 hours, got itchy, got left, got in the car, went back drinking again, ran the car off the road over a cliff. EMS got to him, pulled him up, law enforcement saw him, dusted him off, went to the ED, then went to jail. Then about 4 hours in jail, went back to the ED for their busted spleen and other injuries that ended up going down to Harborview. And
Okay,
the transportation thing. And so there's got to be a way to safely get that person from the facility to the ED if that is going to be a requirement when they knock on the door. That's such a tragic and preventable thing in my mind. So transportation. So, maybe the question is, what would you need in the way of transportation services to safely get people to the ED if they're not fit for the stabilization center at the moment? And the fire chiefs would tell you that 911 is not the answer for that. And then taxi, maybe that was the way they did the old days, but sometimes you put them in a taxi and they went somewhere else too. So that didn't quite work. So transportation would be, I think, a huge thing to solve for this.
okay. That, I know of an incident where somebody was arrested for DUI, and at the time they were not booked into jail, and they were taken home, and then they got a cab to take them to where their vehicle was while they were still intoxicated, and drove back, and there was a pretty horrific accident that resulted from that. So you're right. Safe transportation is going to be one of those things. So we're starting to make a list of potential things that could impact whether or not the stabilization center can actually offer the service everybody, including them, I suspect, would like to the community in need. So anything else? Okay. So Barry?
No, I was just gonna say, good job, Wendy. You did a great job in Caleb's absence. You were the idea person too.
I have my moments. Most of the time I have to be careful because what was it? Somebody told me I was a dominant personality, which sometimes, but I figure most of the people here are pretty strong-willed, so that works out just fine. All right. So is there any other business that we've got, or any other conversation that people would like to have? I can tell you that I know, because this is the data gathering group, that Caleb has, and to an extent, I've been working with IT for the professors over at Wazoo, getting some of the data to look at some of the aspects that the Vera Institute sort of looked at a number of years ago, and seeing kind of where we're at right now. Part of it is a little bit of the same problem we're talking about, in that sometimes we don't get good information from offenders who are coming into the system. And then because there are so many different systems that tie into how somebody moves through the criminal justice system, I'm suspecting the docs over at Wazoo are going, oh, we had no idea. So it's a good challenge for them. It stretches their whatever.
Yeah.
So, but I know that Rick Anderson over at IT has been working, and he's got a brain that usually is able to, at least he's familiar with the jail system, to pulling stuff out. I'm not sure how well it's going to connect up with some of the others.
I know I've been CC'd on some of those emails from Jennifer from WSU, and they're really cranking it hard. They're really looking for a lot of data. So it'll be interesting to see the results.
Yeah, it will be. I'm interested in it too. One of the things that I had asked Rick to, I knew I'd remember the name, Rick to pull together to me was 5 years worth of just bookings and people who've been, that I wanted their name, ethnicity, and how many times they've been booked in a 5-year period. We kind of disregarded the people who had only been booked once because everybody makes mistakes. 2 is still a fairly large number, because a lot of times people will come into jail, be released, and then have to come in and do their 1 day in jail for DUI. The thing that surprised me a little bit, we had 2 offenders who had been booked in 24 times in a 5-year period of time. And so then part of it is backtracking, and I'm suspecting, because I haven't had time to run it down yet, I'm suspecting is the reason that both of them were involved in our recovery court systems. And what happens is the judges will occasionally decide you need to go in jail for a day or two to remember why you don't want to be in jail, and then we'll put you back on the program. So those are the folks we're starting to parse out, and I'm really going to be focusing on 3 or more bookings, but it's a fairly large data set. And that information may go to Dr. Jennifer at Wazoo if she's interested in it, but it just takes it's time intensive because you gotta double check and then back and forth between the Spillman systems. So it is interesting though that we have, it's like a lot of things. We've got a core group of offenders who keep coming back over and over and over again. And that was a discussion that has come actually from, I think it originated with somebody in the council about the reentry services that somebody had suggested out of the council, and I don't know who it was because I got this like fourth hand, that they wanted everybody who was leaving the jail to have resources and ideas and what they needed to do out in the community so that they didn't come back. And my suggestion at some point before I leave is going to be, you don't need to focus on everybody who comes in. You need to focus on those folks who may be 3 or more bookings in a finite period of time, because those are folks that are starting to run into trouble. And it's like they say, if you take resources and focus it on the top 20% of people who are involved in whatever the system is, you make a huge impact on what that system is. If you take resources for the 20% of your kids who are starting to drop out of school because they have an undiagnosed learning disability or whatever else, you put resources with that 20%, the impact not only on them, but the entire system is enormous. And we know that the same thing will happen, or a similar thing will happen in the criminal justice system. So, but that's a proposal. I'm going to leave a couple of them with Caleb and the sheriff's office and the county before I retire, because I think that we can target everybody in these meetings and the meetings that I listen to that I may not be a participant in. Everybody wants to try and provide resources so that people can live their best life, which doesn't involve most of the time rotating in and out of the criminal justice system. And so maybe focusing on some of those folks who truly want it, but struggle with figuring out how to, is going to make a huge impact on them, their family, and the community. So that might be something to file away.
Well, Wendy, I'm glad you're going to leave us with some of those things, because then there's a few less things that we'll have to track you down and ask you after you're gone. And there will be many, but thank you for that.
Caleb and I have been having increasing conversations, and he said, "That's okay, Chief. I know where you live, and it's only 5 minutes away." And so, yeah. I don't know, but it's good to get fresh ideas and fresh people in. So, yeah. Well, Jill, do we have anybody who would be members of the public who might want to ask questions or make comments?
We do have a couple of attendees today. One person has his hand raised. Jason, go ahead and speak to the committee.
Hi, yes, my name is Jason DeForest. I'm a local business owner. How are you folks?
Hi, Jason.
Why aren't we talking to the people that are actually involved in these incidents as opposed to the officers and the hospital staff? It doesn't seem like we're following up with the people who are actually going through these incidents.
Are you talking about the individuals that say EMS or law enforcement wanted to get into the stabilization center?
I'm speaking particularly to anybody that's involved in an interaction with the law enforcement or the hospital that's having a mental health crisis of any kind, or really a drug crisis, because it seems to be that's what you guys are really focused on, more so is the drug side of things. But I've got firsthand experience being in that hospital with police during a mental health crisis, and all of the members of the police department, including the hospital staff, did not handle the situation appropriately. It's a very different thing to put all this stuff into place, but how do we know that these officers and these hospital staff are actually doing what they're supposed to do, and who's holding them accountable for that?
That would certainly be information that would be very important. I know that there are some organizations, and there's an ombudsman that exists for the North Sound, but if people don't know that that's a place that they can go to say, hey, I was involved in this either directly or indirectly because it was a family member, and this is the way we were treated, and we don't feel that that's okay. And I absolutely understand that. I can tell you if it would help. I realize my official scope is with the jail, but I wind up talking with a lot of members of the community who utilize the systems directly or indirectly. And you would certainly be welcome to give me a call or come down to the office. And if you wanted to sit and talk about it, I might be able to give you some direction as far as who else that had more authority in the mental health field than me, who might be useful for you to talk to.
Okay, I appreciate that. And I think just to hit back to what I was saying, I think it'd be really important to talk to the inmates at in processing and at out processing.
Mhm.
You know, inmates or people involved in this situation, I call them inmates because that's essentially what we're doing right now. We funnel them through the hospital to the jail. Talk to these people and find out what we could do for them to get them help. What do they need, right? Because if we just ask, what can we do to help you? Perhaps that can solve a lot of problems.
That's a very good observation. I appreciate you being willing to bring that to the group.
Thank you for letting me talk. I appreciate it, Wendy.
You're certainly welcome. Jill, is there anyone else who might have some comments or questions that they have?
Thanks, Wendy. We have one other attendee. If you'd like to speak to the committee, please virtually raise your hand now. And no additional hands are raised. Barry and Raylene, I've got a couple questions for you after the meeting, if you don't mind sticking around. Thank you.
Will do.
No problem.
All right. Well, thank you very much, everybody. I think that we may have given ourselves some more work to do, but I think it was a very beneficial discussion. So I really appreciate everybody bringing on this beautiful day, being willing to come to the meeting. So thank you. Y'all have a good rest of the week.
Everybody, take care. Have a good one.